talking about stability, hopefully these principles, these ideas kind of are transferable across like multiple conditions. So not just looking at like one thing and then just like kind of only using skills for sort of one pathology. Hopefully this can kind of apply across the board. For me, stability has always been kind of like a nebulous term, but kind of the definition will vary from person to person, and I think like that's where I kind of got lost in trying to like navigate my way through progressing and regressing through stability. Like a lot of people, or in the world of like social media, everything will talk about like, oh, you have like unstable hips, unstable scaps, and like I never really knew what that meant. Like try to get like a firm definition on it and like kind of piece it together. Kind of took a little bit for me. But for me, stability is kind of like a big thing in terms of the clients we see. So like when we think about developing strength, right, like stability is typically a prerequisite for that, right? So if you're looking at like a shoulder press, right, that shoulder needs to be stable for you to exert some force, right? And you can't have output without stability at some point within the system. And that kind of goes for like developing a skill for a movement. So like if you don't have the stability, you're probably not going to develop any sort of like skill acquisition with any of the movements. So like, do any of you play hockey at all? No? No one? Okay, cool. But like an analogy I like to think about is like, you don't teach like your little kid how to shoot the puck first. Like you gotta teach him how to skate, get like that foundation first, and then teach him how to shoot. Like, because if you teach him how to shoot, put him on skates, he's gonna look like Bambi on ice, and like it's just a prerequisite to like the skill of shooting. You need to be able to stand on 2 feet. And then when we think about like us as humans, right, like we're biped creatures, right, like that's kind of what makes us who we are. We're like creatures of like energy conservation. So like being on 2 feet is kind of a big deal. And then if we kind of go into things like this, so before kind of diving into stability, I kind of like to differentiate like muscle function, muscle action. So like when I think about muscle function, a lot of the term functional is kind of out there. Again, another nebulous term where like people's definitions will kind of vary, but like my definition, kind of like the information I've been exposed to, is like muscle function is kind of how we behave when we, spelling mistake, breathe and walk. So like looking at gait mechanics, looking at respiration mechanics, similar to what like Dan covered last week, like how those muscles are functioning in those sort of domains. And then when we look at muscle action, you're looking at how when we move it from origin to insertion. So like if you're taking like a glute med, like a common culprit, if you're looking at the action, right, you're looking at like your abduction, your clamshells, external rotation, like an open chain sort of situation. You're moving like the insertion closer to the origin, right? You're putting some tension on those fibers and going through somewhat of a range of motion. But like when you look at the glute med like as a function, how it how it's functioning through like day-to-day life, like when you're looking at like the Trendelenburg sort of sign where that hip's dropping, it's not necessarily a muscle action where you're going from insertion to origin, right? Like when I'm walking, my foot's on the ground, I'm not out here. So you're looking at how is it stabilizing the pelvis in that frontal plane as you kind of shift towards it on one leg. And muscle function kind of synonymous with like an intrafusal muscle fiber and like an autonomic nervous system. Like the intrafusal muscle fibers are like the ones that are kind of coiled up with the muscle spindles. It kind of creates like that feedback loop where, as the muscle stretches, it kind of like contracts, right? That's kind of creating that proprioception within the muscle, sending some sensory information up to the brain, and also sending like some motor input into those muscle fibers. So all that is like unconscious, right? So like as I step, I'm not thinking about like my glute med like contracting super hard, like it's stabilizing itself just through like that feedback loop that doesn't even reach the brain yet. Whereas if I'm looking at something like a clamshell, external rotation, abduction drill, like that motor pattern's coming up from the brain, I'm sending it down. There's no sort of sensory information coming up from the muscle all the way up a little bit, but like you're looking at more of a conscious movement, right? So like this, a little bit more conscious versus when I'm walking, like not really thinking about how is my glute med stabilizing itself as I go through gait. So like distinguishing like function and action has been a big thing for me, just trying to, as I prescribe exercises and like how I can sort of progress people sort of through their treatment plan. And then if you look at like mobility, stability, strength, these are kind of the 3 adaptations I'm trying to create with almost any intervention. So with any intervention I'm trying to prescribe, like I kind of want a end destination and goal, or using some sort of purpose, right? So they're kind of prerequisites to each other. So like mobility, like freedom of movement, able to, you know, actively get my hand over my head. And like stability is like the ability ability to resist force, and strength is like the ability to exert force. Kind of touched on that, where stability might be more synonymous with like muscle function, so that resisting force, unconscious sort of autonomic nervous system action, and strength would be like your bicep curls, like my ability to exert force, right? So if you're looking at like a rotator cuff, for example, right, you have your banded ERs where you kind of like, you know, going through a little bit of range of motion, origin to insertion, putting some tension across those fibers. That probably lie more in that strength sort of area where you're kind of using the muscle action there. But if you look at like the rotator cuffs as a whole, you got like all 4, who can name all 4, like supraspinatus, infraspinatus, teres minor, subscap. Like their job is to stabilize that humerus within that scapula or glenohumeral joint, right? So as I go through flexion, as I go through like abduction or sort of any weight bearing, like the collective job of those guys is to stabilize that joint, right? So that would be more of that ability to resist force. Right, so again, prerequisites to each other. So for mobility, right, like for stability to occur, like you need to go through into a position of instability, right? So overhead position, right? If I can't get into an overhead position, like these muscles aren't going to be able to like stabilize, because if they're just down here, they're not really doing anything. And then stability, same thing, like it's a prerequisite for strength. Like if you're not stable at the joint, like you're not going to be able to sort of push any weight. And then that's kind of the vehicle in which the stimulus that we're driving to create those strength gains that, you know, ICBC wants to see. And then when we think about like how we're communicating this to patients, I know it's kind of in the weeds when it comes to this. Like a lot of times I've been guilty of it. It's like, you know, you got a weak core, or you have like a weak serratus, which is leading to like unstable spine, unstable scap. But like if we're distinguishing muscle function, muscle action from each other, like they're 2 different adaptations, right? They progress on a different scale. They, you know, different stimulus, different muscle fibers, right? So if we're looking at like weak obliques, like if I say, hey, you have weak obliques, like Gen Pop person's gonna think, okay, like weakness, I should probably strengthen it. Bring insertion from towards an origin, use that muscle action. But like all of us know, like obliques function, stabilize spine, right? Resist force. Like we're all pretty good at like, you know, putting like the anti-rotation, anti-flexion, anti-extension, anti-frontal plane, lateral flexion movements within our treatment plans. But I think it kind of gets lost when it gets towards like things like the serratus or things like the rotator cuff, right? Like if we're looking at like, is the serratus weak or is it just unstable, right? So you're looking at like those push-up pluses, like you're going through that range of motion, not really resisting too much force, but if you look at the function of the serratus, stabilize within upward rotation of the scap, so like anything like a landmine press, a shoulder press, like that serratus is technically doing its muscle function as we go through those upper body movements. Although it might look like training, right? Like that's kind of what we try and get people to do, right? We try and get them from rehab and sort of progress them towards more exercises that, for me at least, reflect like a training that kind of look just generally like a workout, right? So like we're using like, and it kind of keeps them more engaged, right? So if we're doing our banded ERs, great, but we do have to eventually integrate some muscle function into like their treatment plans. So like if stability is such a big thing for me, it's like, you know, we should probably assess it, right? And it's kind of been a question that's come up in the past, and like assessing stability is kind of gray, right? So if it's something that's unconscious, right, like we're not consciously thinking about it, it's quite hard to assess. There's not really any gold standard to assess stability, but I think the problem with that is that we don't really have a solid definition for stability. Like gonna pick on someone who wants to try and define stability. Yeah, laugh, your hands up. What if I'm like one of your clients, I'm like, hey, laugh, like you're saying I have like an unstable scap. What does that mean? Right, perfect. Bang on. And then that's more about like a local joint sort of lens. If I was to look at more like a global stability, like this, like standing on one leg. Like some people think like, yeah, like stability kind of equates to, balance, right? Stability and balance, like the odds or the likelihood of you falling over. For me, like balance is kind of like the result, right? So like you need stability to have balance, right? It's not like a two-way street, if that makes any sense. Like I can't have balance and no stability, right? Like if I can't, like to improve balance, I work on stability, right? So if you look at like a definition of stability, like I kind of came up with this, it's subjective, right? Like if it's always kind of evolving, hopefully. Like the ability to maintain your center mass within the base of support through the management of like your internal and external forces. So center mass, feet, base of support, where I'm sitting, right? Like this, pretty stable, right? If I manipulate this to like 1 foot, base of support's a little bit smaller, my center mass actually has to shift over within the base of support, right? That frontal plane shift is me acquiring, or like me exemplifying like that stability. And then like the internal and external forces, I think this is where we like to test. So it's hard to kind of replicate the internal forces. Like what does that mean? Right, so like if I'm in a kettlebell bottoms under press, right, it's like you can see yourself like trying to keep it balanced, right? You're trying to keep like center mass within this base of support, but you can see those like on and off, those sort of perturbations that are happening internally, and that's hard to assess, right? Like it's kind of like that coach's eye thing where it's like, man, that doesn't look stable, but it comes to like our ICBC report and you're like, well, I put this kettlebell over his head and his arm was kind of doing this, and like they're like, that doesn't really make sense, because they're not us, they're not coaches. They're looking for like, if I push like 5 out of 5 on that Oxford scale onto his hand, can he resist it? Like that's your ability to resist external forces, right? So it's a subjective thing. It's tough to assess, it's tough to define, but like that's what makes you guys so good. You guys can use that subjective information and sort of put it into practice. Like that's what makes you different than like the AI. The AI can do the X's and O's, 3 sets of 10, and like not assess the subjective things. But like if we're gonna want to keep our jobs, I think the subjective thing is important, right? Like that's what makes us different than just the robots. And then if we kind of unpack stability, like how do we not falling over, right? So I think kind of categorize into 2 things. There's like internal stability, so like thinking like squats, right? Core, bracing, knees, hips, everything's kind of firing. You're not really relying on the external environment. But if you have someone that's, let's say 75 years old, never squat in their life, and walking is like the limit of their physical activity, they likely have a difficulty accessing internal stability, right? Like that, teaching someone how to brace their core is like day one, something we all try and do, right? Just because it'll help them sort of create that foundation to then learn skill, to then develop strength, right? Because without that, they're not able to express any of those sort of qualities that we're looking for. And then we'll kind of just give them some external stability. Has anyone ever just given someone that's, they're in a split squat and they're like all over the place? Easy thing, just give them 2 dowels, right? Like you just instantly gave them some sort of reference point. If you give them like the dowels, and if you go back to this definition of stability of keeping center of mass within base of support, you just increase their base of support by, I don't know, 2 times. Not so good at math, right? If you have 2 dowels there, right? And then you can slowly regress that. So like using external stability as a tool to help progress and regress exercises, like seems simple, because we all just naturally like, oh, you can't stand on 1 foot, put 2 feet on the ground. You can't stand 2 feet like and squat. It's like, okay, we'll give you something to hold on to. We'll give you a barbell to like hold on to, or 2 dowels, right? It's just kind of intuitive for us. But I think thinking about that and sort of putting these ideas out there and sort of setting like a model of like what kind of framework are we using to make these decisions instead of just like, oh, I know, like it's simple for us, right? But like explaining that to a client, they're like, why do I have to have the dowels? It's like, well, when you squat, you're all over the place. So we're going to teach you how to squat, bigger base of support, and then we'll slowly regress that. Right, so external stability, easy tool for us to kind of manipulate, but like in the grand scheme of things, I think our goal is to improve like the internal stability, right? Improve their function. And then if you unpack that a little bit, so like if we're branching off from like internal, external stability, we're gonna kind of go towards the internal and kind of branch off a little bit. And then look at like unpack like what is internal stability. So like again, just categorizing it again, trying to develop like that framework. You have functional stability, structural stability. Like structural stability would be like your passive structures, your ligaments, your menisci, labrums. Whereas you're looking at functional stability, muscles, how are you managing center of mass, what's your base of support. Things that you can change pretty easily. Like for us, it's hard to manipulate or create like a stimulus to create change through labrums, ligaments, menisci. Tendons a little bit different just because a little bit more of a contractile property in those guys. Whereas functional stability, this is something like, this is our bread and butter. This is what we work on day in, day out with all of our clients. Like who's ever sprained an ankle? Okay, no one's played hockey, but someone's got to roll an ankle. Who's rolled an ankle? One, just one? Two, I thought we were athletes, 3, 4, 5, come on, right? Kind of a pain in the ass, right? Like you roll an ankle and you know, it gets better, but like the frequency and re-injury rate on those guys are so high, right? Like, have you ever seen like, you just kind of roll and you're like, oh, again. It's like, because if you look at the ankle, you got what, you got a couple muscles that can kind of contract, what, your peroneals, Achilles, sure, and like tib post. Little guys, they're not too big. There's a lot of ligaments there, right? Like the ankle depends very heavily on your structural stability, right? You got so many ligaments, but like one, contract your ATFL. It's not happening, right? Like it's hard to drive a stimulus through that ATFL like directly. Like that's where things come up, where you're balancing and kind of creating like that proprioception within those other muscles, right? You try and increase their functional stability, like the tib post, tib and peroneals. You're trying to use like, okay, if I lack the structural stability, like, yeah, it could heal, right? You could roll an ankle, create some tissue damage. It can heal over time, but sometimes, you know, the tissue healing isn't always back to 100%. Otherwise, re-injury rate would not be as high, right? So we're trying to increase the functional stability of almost like all of our patients that come in. But whereas if you have like a shoulder, probably less common, who's popped out a shoulder? Okay, good, honestly, probably for the best. But so many muscles here, right? That cross that shoulder joint, rotator cuffs, pec, lat, delt, bicep, tricep, all a bunch of big players. Not too many ligaments, a couple, right? But not like the foot, right? So the shoulder, unstable joint, but has a high reliability on functional stability, like your muscles, right? So when you pop out your shoulder, it's like, oh, like I know how to rehab. There's muscles that I can strengthen, muscles that I can teach to kind of, like I have a rotator cuff tear. Say I have a full tear through, let's say supraspinatus, right? Like not all the patients get, I'm not sure like if you guys know, like they're not all gonna get surgery, right? So we gotta find other ways, like other muscles to kind of pick up the slack, right? We can't just be like, oh, your rotator's cuff torn, you're tough luck, like your shoulder's gonna be unstable for the rest of your life. It's like, that's not true, right? Because there's so many people where you have a scan and they have a rotator cuff, but they have no symptoms. It's like, oh, this is strange. And it's like, likely because there's just so many muscles there and they're just collectively picking up the slack. That's kind of how I see it, but again, up for debate. It's just subjective sort of interpretation. But like differentiating structural and functional stability is kind of useful for me because then it's like, this is what I'm trying to influence. I can't do too much about like the medial meniscus that has degenerated in my 59-year-old patient, likely not getting surgery because they're not doing anything athletic. They just want to have a knee that feels better. Right, so like when we look at functional stability, it's like how are we improving that, right? Like if we circle back all the way to that definition of stability, you know, center of mass within basic support, it's like those are two variables that are pretty easy to manipulate, like with those two dowels, but like that's pretty kind of intuitive, like that basic support. Oh, you're pretty good on 2 feet, go on 1 foot. It's like, okay, cool. But like, what about center of mass? Like, how are we able to manipulate their center of mass to kind of create a stimulus that drives a stability challenge, right? So if I'm holding a backpack, right? Pretend this is a dumbbell, right? So if I'm pretty good on one leg and I'm just like this, it's like, okay, like I could give him contralateral load, he'll have to shift a little bit more, right? If I'm here, right, like my center mass has to shift this way on one leg. Otherwise, like I'm just gonna fall over, right? Like I'll naturally, instinctively go this way. Vice versa, if it's an ipsilateral load, my center mass is going to go this way, right? So we can use load to make things a little bit more challenging, but also can make it a little bit easier. How many people do like a body weight squat and it's like pretty bad at it, right? Like I'm terrible at a body weight squat. I can maybe get to like 90. I throw myself like kettlebell 10 pounds and like I can go like ass to grass, right? Versus here, I'm gonna turn the camera off. Here I can get to like here and I'm like, this is as far as I'm gonna go and it feels terrible. But we can use like load to make things harder, to make things easier, vice versa. Like that bottoms up kettlebell, like again, you're manipulating their center of mass. We're like, now we're overhead, or like even like your farmer's carry. It's like, okay, like if I'm doing a farmer's carry and I got more than like 5 pounds, where it's like, you should see a shift towards that side. Because if I have 40 pounds here and I'm like here, it's like, I should shift a little bit this way over this foot to kind of counterbalance that. That's fine, right? If I see them like this, it's like, okay, well, come on. Now that's more of like that compensation where it's like, we're not really using any sort of functional stability. We're just pushing everything over here just to kind of counterbalance it, right? So I think using this way, like manipulating center of mass can be a nice tool that we can use to kind of teach them stability. Like even like your tandem stance, kettlebell, pass it back and forth. It's like, why is that so difficult for patients that have difficult, like they can stand on one leg fine, but as soon as I give them this, toss it back and forth, like they have to calibrate for that change in center of mass to keep center of mass within basic support, right? So like just like that. But a lot of my clients, like especially like the ones that haven't been exposed to like single leg loading, like we all can do like a split squat pretty easily, Bulgarian pretty easily, but like a lot of our clients haven't been exposed to spending a lot of time on one leg, right? So as soon as we do that, and then we give them this challenge, like, whoa, that foot starts going like this, that hip starts going, and they kind of wobble around. It's like, hey, we're kind of driving that stability challenge through this sort of stimulus just by literally passing the load. That's kind of both, right? Doing a split stance, and then you're just manipulating center of mass. Cool. If we go through an example, we can walk through this together. There's a couple that we'll do on our own later. Like simple movement is like a barbell standing shoulder press, right? So like in space, not a whole lot of external stability, overhead position, unstable position, right? So like you got to reduce space of support compared to like a seated shoulder press in a Smith machine, right? Like reduce space of support in standing compared to like sitting. Non-fixed barbell pass, so like if I'm in a Smith machine, right, like it's designed for output. It's not designed for stability. It's on a fixed path, right? Like there's only one way to go, and it kind of provides you that external stability. So like if I got someone, I'm like, that overhead dumbbell shoulder press looks kind of iffy. It's like you could regress maybe to a barbell, but like likely if they don't have that stability, they probably don't have that strength to lift a 45-pound barbell overhead. It's like, okay, maybe we do like a seated Smith machine where now like we've given them the external stability. We'll give them a vehicle to kind of drive some strength output, and then you're sitting. There's less of a stability demand on the lower body because it's fixed. You're sitting down. You can't fall down because you're already down. Versus like, if I'm standing overhead, right, like hips gotta engage, core gotta engage, and now I'm overhead, it's like, you're asking a lot of this person, right? Like not a lot of, just personal experience, not a lot of my ICBC clients are doing barbell overhead press, but like I still wanna drive some sort of strength gain, like say rotator cuff, say shoulder, say just upper limb functions. Like, how am I gonna do that if they can't stabilize overhead? It's like, just give them some external stability. And then, obviously this is one regression to progression, and then like you could create more of like a cascade of progressions and regressions. Like if this isn't working, it's like, okay, like maybe we go seated. That's even harder. Like seated Smith machine's pretty stable. Go.
If you do the overhead press, they can't do it. And you press to that. Wouldn't that be like not stability? The bottom one?
The bottom one.
Yeah. Would that be stability?
Like seated?
Yeah.
You'd be more stable than standing for sure. I think so. Your base of support's a little bigger, right? So if I'm here, right, 2 feet, I don't know, little rectangle, versus if I'm sitting, right, like bigger base of support.
For the shoulder.
Oh, for the shoulder.
The overhead press would work.
Oh yeah, this is kind of a bad example. Maybe like behind the head, obviously, like debate on whether to do that or not. Like I just needed to find a picture with like the stable machine, right? Like if I don't have a Smith machine and like this is too hard, you work in Surrey, right? You and Vincent, right? Like you guys have access to machines like a shoulder press machine. It's like, that thing's designed for output. There's like, you're giving them the most external stability as much as you can, really. It doesn't get any more than that, right? You're seated, it's literally fixed, it's pin loaded, so like it doesn't have to be as heavy as a Smith machine. It could be like 10, 20 pounds, right? And then you're just kind of giving them like, hey, this is what the arm path is, and then eventually you can slowly progress it instead of just loading up the shoulder press machine. Like, oh, we did 40 last week. Okay, let's do 50, and so on and so on. It's like, okay, maybe let's progress to something a little bit more unstable, a little bit more reflective of what you're going to be exposed to, like outside of the gym. Like that's kind of how I see would be like your progression and regression. The shoulder joint, like it's kind of the same path, but like just because this is like free floating, like now here it's like I could tip this way, I could tip this way, tip this way. It's like if I'm on like a machine or Smith machine, it's like it's only going up and down, right? Like there's no deviation forward or back that I have to kind of worry about. So like that's kind of like a tool that we can use. I know like at my gym, like I don't have machines, so it's kind of hard to manipulate these sort of variables, which is what we're going to think about when we do our group exercise, because I know this doesn't apply to all of you, where it's like, oh, like I have a barbell, I have a Smith machine, I have a seated, Cybex shoulder press machine. Like not all of us have that, which is fine, but like we kind of have to play with what we got. So like if we assess stability, it's so subjective, right? Like I think like just getting comfortable with that and getting away from like the ICBC kind of drills it into you, where they're looking for, like even in today's meeting, it's like they want objective measures, but like providing them an objective measure on stability is like next to impossible for them to understand, which makes it tough like on us, because it's like we want to do our jobs, what's best for the client, and then like we're kind of handcuffed and strapped by like the constraints that they give us. But like just getting more comfortable, like hey, it's more stability, like it's more subjective. Like it's okay to be like, hey, Juan, that split squat looks better. Like that should be something that you can say to your client, like, and like have something to back it up, not just like, oh, like that just looks good, but like having that in your mind, like, oh, actually like 3 weeks ago, like Vincent was kind of like this as he was split squatting or doing his like single leg hinge, but now like, oh, thank you, good. But it's just like, okay, like using those can sort of help you guide your treatment plan, and sort of, again, it might even help sort of improve them. It's like, hey, like it may not be stability, it may be strength, not be strength, so let's take a look at something else. Maybe you can refer them out to something, maybe you go down a different path, maybe it's a cardiovascular issue, I don't know. Kind of covered it, like why does this matter, but in terms of like the treatment side of things. But if we look more towards like injury risk, using stability as a vehicle to like manage our load management. Who watches basketball? Yeah, everyone. This guy, this guy doesn't play. This guy's definition of load management is either I play a lot or I don't play. Right? There's nothing in between for this guy, and he still gets hurt. It's like, okay, like what is going on? I'm not saying that this stability principles will prevent his injury. Injury prevention is a whole other topic. But if we look at like the core of like what's going on, it's like when something is injured, the applied force is greater than your tissue tolerance, right? I think we've covered it in like the bucket analogy with Lillian's and her like tendinopathy stuff. So like tissue tolerance would be the bucket, right? Like if I have a small bucket, applied force would be the water. I'm not going to be able to hold a lot of water. Again, I'm not going to be able to tolerate a lot of force, right? But if I get a bigger bucket, I can probably create a lot, hold a lot more water, withstand a lot of force. But that's kind of what I've done for what I've mainly focused on. But sort of we look at the applied force and ask like, why is there so much force going through it? It's like I get pain in my knee when I back squat. I don't know, I don't back squat 3 plates, but like someone that might come to you and say that, it's like, okay, like you're a pretty strong guy, back squatting 3 plates. Maybe let's look at like what's going on. Maybe you got that crazy hip shift where you're just like this and coming down. It's like, okay, like instead of saying, okay, we're gonna rebuild your squat from the foundation, get rid of that, and like deload them completely where you're not playing or you're not squatting, right? That's kind of what we want to stay away from. Like when people have pain, you don't tell them like, depends on the injury. You generally don't tell them stop everything you're doing, right? Because like we all know, like if you just stop exercising, if you just rest forever, like things might get better, but like things also might not, and then you're deconditioned and now you detrade. It's like we always want to encourage them to kind of keep moving pain-free. So like if we use stability as a way to limit load, right? So like if I'm get knee pain when I'm back squatting 3 plates because I'm just only on my right leg. It's like, okay, let's just dial it back. Maybe do like a Bulgarian, a single leg, right? I'm not loading 3 plates in this. I'm like reducing the load, but I'm still giving them a stimulus that'll kind of elicit some hypertrophy, elicit some more stability improvements, right? Like I don't have to completely deload him where he's sitting on the bench in street clothes. I can, maybe play him half a quarter, right? Like kind of in the preseason. I can gradually build it up without him feeling like I'm not doing anything, right? Like don't draft him in your fantasy league this year. It's used to gradate load, right? Manipulating stability, really effective way to limit load, but still drive home some desired outcomes. And progression, again, like because it's subjective, doesn't always need to be like, okay, we did 40 pounds, we did 50 pounds, right? Like it can be subjective. It's like, okay, that felt easier. Like when things feel easier, but the load's the same, it's like, yeah, you got stronger, but it just looked better. Like sometimes it just looks better. And then like unpacking, okay, why does it look better is kind of something that I'm trying to develop, but still, it kind of comes with more seeing, I think, reps really, because like everyone's gonna squat different, everyone's gonna perform an exercise different, so being able to apply like kind of a general framework, but also in a very specific context has been kind of difficult, but would be really useful as something that, like treating such a wide variety of patients. Okay, this is something that we could unpack today, or save it for later. But like just touching on like stability, kind of goes hand in hand with proprioception. Yeah, right. Like if muscle spindles, Golgi tendon organs, right? Like that's how we get the sensory information of where we are in space, what our muscles are doing, right? Those guys. If we look at like, has anyone heard of the pain gate theory? Couple nods, okay, no, not so much, okay. When you bang your, let's say shin, someone kicks you in the shin, you're playing soccer, you're not wearing shin pads because you're like me and I don't own shin pads, and nor do I play soccer a lot, but like someone just toe punts you in the shin. Natural reaction, what do? Make it feel better, right? What's something that you might do to make it feel better? Yeah, rub it, right? So, it's not fixing it, right? It's not creating a cascade of healing processes where it's like, if I rub it, oh yeah, it's not repairing my tissue, right? It's driving a nervous system change in terms of how our brain is interpreting words, the pain, right? So if we look at nociception, pain kind of goes from, let's say I bang my knee, from my knee to my brain, fast pain, like acute pain, like hot, or like I boot you in the knee, bang your knee against the table, travels about like 5 to 40 meters per second to the brain. The brain can only interpret so much, right? Like, it's pretty powerful. Like, the brain is super complex. Trying to simplify it a little bit, but if you bang your knee and then you start rubbing it, right? Like, the rubbing is like your mechanoreception, like your, I don't know them off the top of my head, they're on another slide. Like the free nerve endings that sense light touch, pressure, deep pressure, and like vibration, right? So like those guys travel like 35 to 90 meters per second. 5 to 40 fast pain, 35 to 90. That's like an F1 car. That's how fast the F1 cars go. Fast pain, like Usain Bolt sprints, what? 100 meters in like 9, who knows this? 9.8, round up to 10, because like math. He runs like, but he doesn't run like 10 meters a second consistently, right? He started and he picked up, right? Like it's a gradual. So he's probably running ballpark 17 meters per second. Fast pain's running at Usain Bolt. Mechanoreception's like a race car. The race car is going to get to the brain first, right? So that's why if it's just Usain Bolt run into my brain, it's like, whoa, I feel that pain, whoa, I feel that pain. Then I use like a mechanoreception, like rubbing it, Theragun, whatever, like rubbing it, let's do that. Like now it's sending a sensory input into my brain and it's getting to the brain first, right? If it gets to the brain first, the brain can only interpret so many things, right? It won't interpret both. Simplified analogy, but that's kind of what happens. So if I'm providing these fast sensory inputs into my brain when I'm in a painful experience, like it might sometimes, let's say, override or block the sensation of pain. Pain's still there, you're just not sensing it, right? Like pain's just an experience, right? We've talked about that, how like that's the interpretation of the brain to some sort of threat. Threat equals me banging my shin against the table. But then if we look at like proprioception, that's like traveling from like your muscle spindles, let's say forearm, for example, 80 to 120 meters per second. That's pretty fast, right? Like that's going real fast. And there's like 50,000 ballpark muscle spindles within the body, not in the face, but like everywhere else. So like if we kind of use the hierarchy of like, you know, it's pretty fast. Like the body is prioritizing this, right? Like if they weren't fast fibers, just kind of my opinion, like if they weren't conducting at a high speed, like I wouldn't really value that much, right? Like the body really wants to know where it is in space so it doesn't fall over, right? So 80, 120 meters per second carries information on position of limbs, muscles, and joint capsules. So like if a lot of people, have you ever seen people that like kind of go up and they have no idea where their shoulder is, or like you get them to like, more of a vestibular thing, but for an example, like when they shoulder check, when you teach like a 16-year-old driver how to shoulder check, they go like this. Like they have no proprioception in their neck to be like, oh, like let's dissociate some things from the other joints around it and not all move together. It's like, okay, like their proprioception is probably quite poor. So if we can improve the amount of like proprioception feedback that's going towards the brain, maybe it can kind of reduce the sort of experience interpretation of pain that's within the body. I skipped over this, sorry. Slow pain is like chronic pain. It's like 0.5 to 2 meters per second. That's like maybe about, I don't know, ballpark, like the 400 meter that you guys ran. Like, Usain Bolt's fast pain, slow pain is like Caden and Juan, right? Like,
Which one though?
0.5 or 2? It wasn't that big of a difference. It was only like, what, half a second? But yeah, like that's kind of how we can influence the nervous system from a neurological surface level without going too deep into like each of the free nerve endings that kind of fall within each of those. That's why like mechanoreception, like, which is like, think about massage, Theragun, like that's why it might feel pretty good and get rid of that slow pain, right? Like that could, you're not really, also like cardiovascular blood flow things, but like you're not healing, like the Theragun's not fixing my torn quad, it's just making it feel better, right? So if you're in a very acute environment like a pitch side or whatever sport you're working with, like maybe we can utilize some of these to get rid of some of this so they can go play, right? Like just a thought.